to the 2026 CRRT SuperUser recap for the e-ICU. My name is Brian Klein, and I am a CRRT nurse educator since 2019, and I will be doing your narration.
As a disclaimer, this presentation is intended for the eICU at UK Healthcare, which is an academic medical center at the University of Kentucky. Always follow your local institutional policies and procedures and observe all local, state, and federal laws.
Our learning objectives today will be to verbalize updates for the CRRT program at UK Healthcare for this year, 2026, to demonstrate advanced troubleshooting using the PACE framework with a focus on remote troubleshooting, to verbalize resources for the proper documentation of CRRT, and to complete the 2026 CRRT validator competency. We'll start with the major updates for nursing for the 2026 year. While not in this year, the ramifications are still being felt of the switch from Baxter to Vantive. As many of you may know, Baxter has sold off its kidney care division to their own standalone company, which they call Vantive. The branding on a few products may change. The phone number, for example, now says Vantive Customer Support instead of Baxter. However, the quality and the consistency of everything is approximately exactly the same. Some resources do still remain on Baxter's website, for example, the user manual. However, the content does not change. One of the new things for the very end of 2025 is the adoption of the Alaris Epic integration. This is a tool to help nurses document more accurate and more timely intakes and outputs. However, it has been a little bit confusing for some folks because Infusion Verify will allow you to do 6, 7, 8 hours worth of I's and O's all at once, which we know is not appropriate for the CRRT flowsheet. We do recommend that Infusion Verify still be used whenever possible for safety and efficiency. However, the user needs to know to document it only 1 hour and then go to the CRRT flowsheet for that corresponding hour. Something that we have noticed pretty widespread is that IV piggybacks are not showing up because the rows are getting completed through one mechanism or another. If there is a secondary that's not showing up in I's and O's, for example, let's say Zosyn, the user can be advised to uncheck the hide completed, which is checked by default on the top of the flow sheet, pictured here, and then they'll be able to find the discontinued row, right-click it, and reactivate it. There have been some minor but significant quality of life improvements on the CRRT order set. The first of which is that the shapes and colors now are associated on the MAR themselves. So for example, on this screenshot right here, you can see that this patient is running CRRT without citrate, and they've got Foxillum 4 2.5 on all 3 scales. Prior to this upgrade, it was a little bit harder to figure out which one went where. It did require the user to read the admin instructions. This still is the case, however, now it'll annotate it with the shape and the color. So for example, the middle one, it says for dialysate fluid, hang on green square if using the Prisma CRRT system. This may not necessarily be present in some uncommon or specialty fluids, for example, the dysnatremia protocol. However, it should be present for a vast majority of the time. Of course, this does not replace barcode scanning. That still must be done for safety. The next minor change is a slight upgrade to the CRRT machine order form. The options have now been switched to bring machine, return machine, and exchange current machine for new machine. Of course, bring machine is to bring a machine to the user, and return machine is to return a machine back to Agility. However, the third option, exchange current machine for new machine, is when a machine is broken. These were made to increase the clarity. These can be placed under first call, provider, really anybody. It's per protocol, cosign is not necessary. This should be used any time that a machine is ordered, returned, or exchanged. The next change are some minor upgrades to the calcium CRRT titration table. They have been updated to show the action that the user must take in changing their lab frequency depending on what level their ionized calcium is. For example, if your drip was running at 45 milliliters per hour and your ionized calcium was 4.1, this shows that you would increase it to 49 and recheck it in 2 hours from changing the drip rate. This minor update was made because of incident reports where nurses had neglected to get ionized calcium levels throughout their shift, and so this was supposed to make it a little bit easier. The link is still on the MAR form. It's a little bit longer now, but it's the same overall link. And this can now be found on Elucid, which is the policy manager, in a more stable fashion. It's also on the CRRT SharePoint, so it's in many different locations. We also made a few minor tweaks to the CRRT order set in order to enhance compliance with Joint Commission standards. The first one was a labs on CRRT, where the instructions for obtaining ionized calciums when on citrate are once again spelled out in instructions. We also have a new order that says apply warming blanket as needed to maintain euthermia. This is because nurses cannot apply bear huggers without a physician order, so this is checked by default in the order set. One of the things that you guys as eICU nurses are really important for is troubleshooting, and the need for broken machines to be processed correctly is really imperative. The nurses should follow sort of a troubleshooting order of steps. The first one is read the screen for tips. By the time they call you in eICU, this screen may not be available. However, there are informational pieces on the screen that are important. For example, there's an error code that usually starts with the letter T, and it's pretty small letters, but those will greatly enhance the ability for anybody on the Vantive customer support to help troubleshoot the issue. Nurses may ask you to call the Vantive customer support on their behalf, and their number is here. However, I think it's probably better for the nurse themselves to call them, because Vantive is probably going to ask them to press buttons on the machine and do things that you won't really be able to do remotely. One thing you can do is call in a work order for the nurses, and this is really important. If a machine is broken, you can call the IT help desk at 38586, and if possible, give the exact error code. Somebody on the unit should then red tag the machine and have Agility exchange it. The nurses, like I said, this is something that you can offer to do because this is something that we're struggling with as an enterprise. Next, there's just a general reminder for the site resources. The CRRT SharePoint is available online all the time, and under Documents, there's a whole bunch of resources, including the presentation that I'm going to give you guys today, as well as the documentation and new hire presentation. We also put announcements up there, really important for you guys. Next, we'll talk briefly about troubleshooting. The troubleshooting method that we teach in new hire class and that we reinforce in the SuperUser class, which we are recapping today, is the PACE method. PACE stands for Patient, Access, Circuit, and Equipment. Whenever you're having trouble, first assess the patient. Are there characteristics of the patient that may be causing the issue? For example, a lot of access and return alarms may be created by a patient who is agitated and coughing, or who may be kinking off the line. In addition, a patient whose filter clogs or clots off fairly frequently may be profoundly septic shock. All of these things can contribute to access, return, filter issues. Next, we have access. A good dialysis catheter is imperative to have any form of effective renal replacement therapy, whether that's CRRT or HD. A catheter in the right internal jugular vein for most adults should be 20 centimeters, 24 centimeters for the left internal jugular vein, and then for femoral vein access, either side, a 24 centimeter catheter is really the only acceptable catheter length. The catheter itself is supposed to sit, if it's in the chest, it's supposed to sit in the right caval atrial junction, and it can go a little bit into the right atrium. A really short catheter is likely to suck up against the side of the internal jugular vein, and it's going to give excessive access and return issues. A chest x-ray might be something that you can look at for the nurse if they're having a lot of these issues. Next, we have circuit. Has your circuit clotted or clogged? A clotted circuit is likely to have a high pressure drop, whereas a clogged circuit is likely to have a high transmembrane pressure, or TMP. Both of these will result in a high filter pressure, which is why it's important to look at the trend on the CRRT machine and try to elucidate which of those two things went up first, and that will help drive troubleshooting. If the circuit is clotting excessively, it may be appropriate to ask the nephrologists if citrate would be appropriate for the patient, versus clogged filters may be a sign of increased solute, such as, like I said, profound septic shock, or rhabdomyolysis. Lastly, we have equipment. Has your machine malfunctioned or required intervention? Is there an error code that we can place on a red tag and put in a help ticket? Or is there something that the nurse can do to troubleshoot in real life? I will have a link to the standalone troubleshooting presentation that goes through the most common alarms in the PDF version that I give to you on the SharePoint. Obviously, the link is not going to work on this video. Next, I'm going to say just a few words about documentation. We're not going to go through the entire documentation process in this video because I've created a lengthy video that's also available on the SharePoint to go through that. We'll just go over some reminders. The quote-unquote new and improved documentation guide, it's actually about a year old now. There's a direct link to it on the PDF I'm going to give you, but it can be found on the SharePoint. In addition, there is a video form of that. It's the PowerPoint narrated in a YouTube video. There's a link on your PDF on this slide that goes through the entire thing. It's a pretty lengthy video. It's about 40 minutes or so, but it should cover anything that you would possibly need to know about CRRT charting, given a whole bunch of different scenarios. We have a patient who goes to CAT scan and is gone for a while and they need to get caught up. She has a massive transfusion protocol and they need to fix the flow sheet to take the MTP blood off. And then she starts and stops therapy. They even fix some errors on the flow sheet made by prior users, so it's worth checking out if you want a comprehensive review. Next, we'll go through what the checkoff is that you guys will actually be signing and put in the file for the eICU. The first thing that is worth saying is that you must do the CRRT at UK Healthcare 2026 Annual Competency web-based training, which is now live on My UK. It is a little bit shorter than in prior years, with an emphasis on a little bit more complicated questions to kind of really test your knowledge, and a little bit more information for explaining the questions if you do get them wrong. So we hope that this will be a little bit more effective than in previous years. Number 1, initiation of therapy. This is part of the checkoff form, so you can bring the checkoff form and follow through with me if you like. First, you're going to review provider orders and enter a co-signature in the electronic health record. This is something that you as an eICU nurse can do. You can be the second signer for initiation of therapy, as long as you can, of course, see the machine with your camera. Just make sure that you put your own name under your own access and Epic on that nurse's flow sheet, which I don't think should be a problem. Ordering supplies for materials management. Materials brings supplies such as the Foxillum bags, the filter set, the Thermax disposable, the blue clamps. All of that comes from materials. Pharmacy does, however, deliver the citrate bags and the heparinized normal saline if that's what they're using for priming. The nurse or you should place an order in Epic for agility to deliver the CRRT machine, as we discussed earlier. And then for you guys in eICU, just to be familiar with the policy on the central venous access catheter and the CRRT policies, which are both listed here. Next, on setup, the nurse will power up the Prismax and Thermax, verifying the correct date and time. This must be done before new patient is pressed, and pretty much once you press new patient, you can't change anything about date and time. The nurse should use the barcode scanner attached to the machine to enter the patient's 9-digit MRN, and then the most recent weight in kilograms and hematocrit on the beginning screen. They'll then put in the prescription, load the filter set in the Thermax, set up the auto effluent line, and connect the filter to the prescribed solutions. The pressure pods and scales should all be identified by color and shape as well as function. So for example, the white triangle is the pre-blood pump, which can infuse fluid before the pump. That can be an anticoagulant or a pre-dilutant, etc. They should also be able to identify the electrostatic discharge ring and blood leak detector. Continuing setup, they should be able to identify the barcode scanner, and they should be able to state that if the barcode is not readable, it can be scanned twice and then put in manually on the third time. They can also identify the return pressure line, the deaeration chamber, the air leak detector, and the return line clamp, as well as how to scan replacement solutions and demonstrate the activation process of the Foxillum bags. Next, running therapy. They should be able to run through the toolbar really quickly and identify the functions of each, the tools menu, cleaning the screen, when a blood leak is detected, the history menu, changing the flow rates, adjusting the deaeration chamber, as well as disable the liquid leveling system, the temperature setting, pressures and filtration fraction, unintended fluid loss or gain, modifying the effluent if not using the auto effluent bag, which is uncommon, and then state that only nephrology can write orders for CRRT. The primary team can contact nephrology to change the orders, but only nephrology teams should be writing those orders. Alarms and troubleshooting, we kind of touched on with the PACE framework. They should be able to identify the common alarms and the fixes for them, such as access extremely negative and turn extremely positive, blood leak detected, Thermax issues, so things like the Thermax not getting enough blood flow, that can be an issue when the prescription is really low. There can be flow errors, which is a result of a bag being unclamped or excess weight being on the bag. Of course, air and blood must be resolved with the blue clamps in the screen instructions. The docking versus overriding alarms. Overriding an alarm essentially tells the machine to continue doing what it's doing, that the user has acknowledged the alarm, versus docking just simply moves the alarm to the dock, allowing the user to change settings while the alarm is still present. If blood is visualized in the effluent, they should get a sample out of the yellow effluent port and send it to the lab with the lab body cell fluid differential, and they are able to get that done stat. They can keep running therapy in the meantime, but if that comes back with anything other than 0 for red blood cell value, the set must be discarded and the blood not returned. Of course, Vantive customer support number is on most machines. It's on the SharePoint, it's on the new user handout, and here it is. We really want nurses to call Vantive before red tagging because Vantive may be able to keep them from getting a set to go down. However, if a machine is broken in a sense that they aren't able to continue therapy, they must red tag the machine and call in that help ticket at 38586. And once again, here is a link in your PDF to the CRRT SharePoint. Regional anticoagulation with citrate. Lab draws are done every 2 hours when a nurse is running CRRT with citrate until therapeutic, in which case they can go to every 6 hours. Calcium drip titration is done per the table that can be found through a link on the MAR that goes to the table on Policy Manager or Lucid, and there's also a copy of it on the CRRT SharePoint. The nurse should get ionized calcium from the patient, be that an art line, a central line, or in some very rare cases, a venipuncture stick, versus the circuit ionized calcium, or Prismacal, is obtained from the blue post-filter aspiration port. This must be done with a small gauge needle. The ABG syringes that come in the stockroom are 23 gauge needle, and that's fine, just no blunt tip needles. Signs of citrate toxicity. This can often be seen with an increased total calcium with a decreased ionized calcium. This can also be seen in late stages with a severely decreased magnesium, and sometimes you'll see a sodium increase because of all the trisodium citrate complexes are breaking off the sodium. A couple things to know on the checkoff for ending therapy. Recirculation can be done with blood recirculation for 60 minutes or saline recirculation, which involves returning the blood, for 120 minutes. Ending treatment, there is a same patient versus new patient option. If they're going to do the same patient new filter, and while reusing the auto effluent, the nurse just must remember to take the 5-liter effluent bag that comes with the new filter set and prime into that. They should never attach the sterile blue line of the new filter to the dirty yellow port of the old auto effluent. There's instructions on screen to do this, but it's often missed. How much blood to reinfuse? The screen will tell the nurse how much extracorporeal blood is in the filter at the moment. However, it should be noted that you should never return more than 100% of that filter volume. Documentation. This is pretty much a recap, but everything is pretty much documented every hour, except for the machine number must be done once a shift. Anytime that therapy is interrupted or ended, that should be documented as well. If auto enter doesn't work, nurses are encouraged to use in-room cameras if available to look at the numbers on the CRRT machine itself to aid in their charting of numbers. However, if nurses are really in a bind and they're not able to do that, it is acceptable to go every other hour. The order to document the INO flow sheet and CRRT flow sheet. Always go INO for that hour followed by the CRRT for that hour. So if there's several hours missed, you would go, let's say that you haven't charted since 7 and it's 10 o'clock, you would chart your I's and O's for 7, CRRT for 7. I's and O's for 8, CRRT for 8. I's and O's for 9, CRRT for 9, and so on and so forth. It has to go in that kind of leapfrog fashion. Override actual balance can be used when a nurse needs to exclude a volume from the CRRT flow sheet that the patient did actually get or have taken off. So for example, a massive transfusion protocol might add a whole liter of fluid to the patient, but the nurse wouldn't want to pull that off on CRRT. In order to do that, they'll go to the override actual balance row of the CRRT flow sheet, and they'll simply type the actual balance for that hour minus the amount they want to get rid of. This can also be done in reverse for patients who had fluid taken off that doesn't need to be included in the CRRT flow sheet. So in that case, let's say the nurse has a negative balance for that hour because a paracentesis took off 5 liters. They would just type in the actual balance plus 5 liters. So let's say the negative balance for negative 4,000. So they type minus 4,000 plus 5,000 and enter, and then it would fix the flow sheet. Can also be used for errors on the flow sheet if a previous user has made a mistake, or for example if you forgot to chart a volume that happened earlier in the shift and you don't want to go back and rechart all those time columns because you'd have to clear your I's and O's as well for it to work. Lastly, kind of the uncategorized is if a patient cardiac arrests and has a code blue, they are to remain on the CRRT machine with the PFR turned to 0. And if defibrillation is attempted during the code, nurses should be advised to not touch the machine during the defibrillation attempt. Patients can and should be mobilized while on CRRT to the extent of their ability. However, during the actual mobilization, nurses may cut the PFR down to 1/2 or 0. If a patient has an unexpected death while on CRRT and the event needs to be investigated, as like a coroner's case, the machine should be maintained on with the current settings on. If you have any questions about validating, and I know it's a lot different in the eICU since you won't have the machine to actually do it, please feel free to reach out to me. Don't forget that you all in the eICU will have access to the same resources as in Good Sam and Chandler. For the 2026 validators, there's a folder that will have everything that I gave the people that went through the SuperUser class as well as the validator training on the SharePoint. The link is on your PDF version of this slide. That will take you directly there. Thank you for watching this recap of the 2026 CRRT SuperUser classes for the eICU. Please send me an email if you have any questions.